Hello everyone, welcome to another video. So in today's video we'll be looking at another topic known as persistent idiopathic facial pain, PIFP. So what is persistent idiopathic facial pain? So persistent idiopathic facial pain is like a type of chronic facial pain that, number one, lasts daily for months, hence why it's termed chronic. So it usually lasts more than 3 months. Then it usually has no clear cause, because usually when a condition is idiopathic, it means there's no clear cause that, like, the doctors have tried, like they've done a lot of diagnosis and they can't really find what exactly is causing this condition. So it lasts daily for months and it has no clear cause, and it usually does not follow the path of a specific nerve, and it also doesn't come with visible signs like swelling or redness. So it is used, this persistent idiopathic facial pain, it was recently known as atypical facial pain because the cause is generally unknown. So looking at the background, like, unlike other types of facial pain like trigeminal neuralgia that we did in the previous video, so this persistent idiopathic facial pain is not usually triggered by touch or by chewing, and it doesn't usually feel like electric shock on the face, or it usually doesn't feel like you are having a stabbing pain. So instead it presents with, like, it's usually like constant. The pain is dull, the pain is aching, and it can shift locations on the face, and it lacks like an identifiable source. So it's not unilateral like we see in trigeminal neuralgia. So there's usually not a cause for this, like there's usually not an identifiable source, like there's no injury, there's no infection, there's no nerve damage. It's just a pain that is just happening from nowhere. So it mostly affects middle-aged women, and it can be psychologically distressing because it is invisible. Like, it's just is invisible, is hard to treat, and it's frustrating to live with. Basically, when you don't know what's causing something, it can be very frustrating. So the face is like innervated rather, and it's supplied with, that means it's supplied with sensation by the trigeminal nerve and the trigeminal nerve and its branches. So in this persistent idiopathic facial pain, there is no specific nerve that is damaged or inflamed, and the pain is likely due to abnormal pain processing in the brain rather than from the face itself, like an abnormal pain that is the brain is processing. So this is why it's sometimes grouped under like central sensitization disorders, where the nervous system becomes overly sensitive to pain. So looking at the pathophysiology, while the exact cause is unknown, is idiopathic, some theories have suggested that it could be due to the central nervous system dysregulation. So the brain like amplifies pain signals even in the absence of damage. Then it could also be due to psychological factors like stress, depression, or anxiety, and it may contribute to the chronic pain loop. Then also maybe a previous dental or facial procedure. So usually some patients develop persistent idiopathic facial pain after like a tooth extraction or a jaw injury, even though the wound has healed. So this has been like a reason whereby like some patients experience this idiopathic facial pain. So for the causes, there's no identifiable structural cause or disease cause, But persistent idiopathic facial pain, it may be linked to nerve sensitization, past facial trauma, psychological stress, depression or anxiety, even having a history of multiple unsuccessful dental procedures. So this does not mean the pain is in the person's head, or like the person is imagining the pain. The pain is usually very real, but it usually originates from abnormal pain perception, not damage. So looking at the signs and symptoms, so the symptoms, like there will be constant facial pain, it will be dull, it will be aching, it will be burning, to be like there's pressure in the face, and then it will be poorly localized, like hard to pinpoint the exact spots that this pain is, because the pain, it can move like to different locations. 1 minute you're feeling it here, another minute you're feeling it in another place. So it's poorly localized, and then it's usually not related to the nerves, so it doesn't follow any one nerve distribution, unlike we see in trigeminal neuralgia. And then there is no obvious cause, like no injury, no swelling, no dental problems, no triggers also, like it's not worsened by touch, chewing, or temperature changes, and it's usually chronic, so it persists for more than 3 months, often years, and then it usually has like psychological impact, so it may coexist with depression, anxiety, or even sleep disturbances. So usually before diagnosing persistent idiopathic facial pain, it's important to rule out like other conditions that could cause facial pain, like we discussed yesterday, trigeminal neuralgia. The difference is that the pain is like an electric shock, like it's sharp and it's triggered by touch, it's triggered by chewing, and the episodes are like brief, like within seconds or minutes. Then there's also something known as temporomandibular joint disorder, where the patient will have like jaw pain, which worsens with chewing. Then sinusitis too can cause facial pain, but it's usually accompanied with congestion, and then it's worse when bending down. Then dental pain too, which is localized to the teeth area. And so there's also something known as atypical odontalgia, which is a pain in the tooth or the tooth sockets, even after going to the dentist. So looking at the diagnosis, so persistent idiopathic facial pain is a diagnosis of exclusion, which means other possible causes must be ruled out first. So this usually includes like having a dental evaluation to rule out infections or abscess, doing MRI to rule out to exclude tumors, nerve compression, or even multiple sclerosis. Then also blood tests, like if a systemic illness is suspected, so we'll do blood tests, run all these blood tests, and then we could also refer to neurology or a pain clinic. So for the treatment, so for the medications that are given for this condition is just for like symptom control. So since this pain is not caused by damage, like giving regular painkillers like paracetamol or NSAIDs, they usually don't help. So we focus on neuropathic pain medications like amitriptyline, which is an antidepressant, a tricyclic antidepressant. So it reduces the nerve pain and it also helps the person to sleep better. Or we could give nortriptyline, which is similar to amitriptyline but has like fewer side effects. Then we could give anticonvulsants like gabapentin, pregabalin, which also helps in trigeminal neuralgia because it's it helps with neuropathic pain. So it calms the nerve overactivity. Then we could also give carbamazepine, which is less effective in this condition compared to in trigeminal neuralgia, but it can still help, and is effective for like chronic pain and depression too. So is when giving this medication, it's good to start low, like with low doses, and then go slow with the dosing, and you can combine with psychological support for the best results. So some non-pharmacological approaches like cognitive behavioral therapy, which like helps the patient cope with the pain and reduce the distress. And there's also something known as transcutaneous electrical nerve stimulation, which may provide relief in some cases. And so looking at the summary of this condition, so this condition, it causes facial pain that doesn't come from an obvious injury or infection, and is due to how the brain is processing pain signals, like a fire alarm going off when there's no smoke. So the pain is real, and while we may not be able to cure it, we can manage it with these medications that I mentioned, that calm the nerves and support the patient and helps them cope better. So in summary, the type of pain that is seen in persistent idiopathic facial pain is dull, is aching, is burning. The duration is constant daily, can last for more than 3 months. It may affect both sides of the face. It may affect one side, it may affect both sides, and it usually has no trigger, unlike trigeminal neuralgia. It usually has no cause, it's idiopathic, and it is the first line treatment given is amitriptyline and gabapentin for symptomatic control, and diagnosis is by exclusion, so you exclude other things that might be causing the pain. So that is basically it for this topic. See you in the next video. Bye.